a lot of members. And I'm gonna close this on my screen. And all right, so I'm gonna go ahead and get started since we're at 36 and I wanna be mindful of everybody's time. Right, there we go. All right. So I did a little mini introduction of myself. My name's Diljit Singh. I'm a gynecologic oncologist, currently the vice president of PNHP, and I've been, God, I can never remember how long I've been involved with PNHP. So we're going to skip that. I currently live in Norfolk, and I am moving to Washington, D.C. in May. Exciting. I lived there for many years and now I'm moving back. And I'm a practicing clinician. I've been in practice for 25 years, and we can continue to talk. So, full disclosure, I usually have like a 90 minutes sort of slide, time to talk. And so I have a very jam-packed 70 slides usually. And so I took on this challenge of like, how many slides did I really need? Now, it turns out we have a lot of members, but I'm assuming you all are here because you want to learn. And so I'm going to just, can we do the whole talk in 5 slides? So, first slide. The United States is the only developed nation that does not provide comprehensive health care. We have 25.6 million uninsured, and of course, we have a substantial number of underinsured, which means people who can't access care because of their premiums, their deductibles, they don't have coverage for the things that they need coverage for, or there are not hospitals, physicians, or clinics available where they are. From some really interesting research done by Doctors Woolhandler and Himmelstein in 2017, and then data recollected, we think that about 37,000 people die a year from lack of coverage, and that in the United States, medical debt contributes to 2/3 of personal bankruptcies, with 77% of those people having coverage at the time they got ill. We have the most expensive healthcare in the world. We spend almost twice as much on healthcare as everyone else. We have worst health outcomes on many measures, and we'll cover some of those. And we don't cover everyone, of course. Third-party entities who don't bring anything to the table take roughly 32 to 35 cents of every healthcare dollar in profit and bureaucratic waste. And that, of course, makes a significant amount of our healthcare expenses. Right now, we spend enough to cover everyone and to add mental health, dental, and vision coverage. This kind of concept that, we all benefit when everyone has healthcare unconnected to employment is something we don't talk about a lot. But, as a group of healthcare professionals, we believe and understand that the best, longest quality life in the safest, happiest society is something we'd like to achieve. And I think something we don't talk about a lot is kind of thinking about the financial and creative freedom we have as individuals when our employment is not the source of our healthcare coverage. And then from that other perspective, thinking about businesses, small and large, free of the burden of providing healthcare, have the potential to be more successful nationally and internationally if all they're focused on is their business, right? Whether it's like making cars or lip gloss or whatever. And then the other piece I don't think we talk enough about is the concept that healthcare is not a commodity, right? There's not a benefit to the free market. And we think the main reason for that in health economic terms is information asymmetry, right? That we don't always know what we need and when we'll need it, right? We don't know if we're going to get a rare form of lymphoma. We don't know if we're going to need fertility care or not. And then there's no time to shop, right? If you're having chest pain, if you break an arm or leg, you don't necessarily have time to shop for healthcare. And then again, that's all just a fallacy, right? Because we don't actually shop. There's our employer's choices, what they give us, or we live in a geographic region for many of us currently, like I've been practicing in the Norfolk, Virginia, Chesapeake area, where like you really don't have a lot of choices. If you want to see an endocrinologist, if you want to see a urologist, your options may be limited. And then the physician challenges are, to me, an important part of why we need to think about fixing our system, right? There is an inherent conflict of interest when what's best for the patient may not be the best for your employer, whether that's a corporation or private equity or a hospital system. And we often talk about the progressive, I've been in practice now 25 years, and the change in the amount of autonomy we had in terms of recommendations we make to patients, the sanctity of the patient-physician relationship, patient trust, and what they believe do they believe that we have their best outcomes in mind when we make recommendations, and how that's changed over time. The limited time we get to spend with patients, between the burden of the electronic billing record and making sure we put in the family history and did our whole review of systems and all the other things which may or may not pertain to the visit of that day. Again, like I said, I've been doing this 25 years, and I will still be like trying to chase down the right code because I ordered a blood test that's slightly different than the other things, and I waste my time figuring out what code it is. And then, of course, pre-authorizations and denials. There's also been this physician wellness movement that in many ways I am extremely supportive of, but the idea that when we're frustrated, when we're worn out, when we feel like at our wits' end to help people, that this is burnout, where if I just meditated more, exercised more, learned a little yoga, blah, 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 that this would solve the problem, as opposed to we have a problem with our whole system that we are reacting to. And so moral injury, and these are two descriptions that Wendy Dean and Simon Talbot make in their wide variety of, they've got podcasts and books, etc. The challenge of simultaneously knowing what patients need, but not being able to provide it due to constraints beyond our control. And then, of course, for the last slide, what's the solution? Improved Medicare, the concept that we provide all medically necessary care, inpatient, outpatient, medical, vision, that we don't have co-pays, deductibles, or premiums, because we know all cost sharing just prevents people from getting the care that they need, that they don't need supplemental or gap plans, that it's equitably funded, and we have a simplified payment design. All right, so that was 5 slides. Is my talk over? It is not, because you're here tonight, and I believe we should talk about the details and give you all data. For those of you who aren't yet PNHP members, if I may be so presumptuous, hopefully the data is eventually data you'll use to talk to people in your community, people that you practice with, as we talk about this. So we're going to talk about who the healthcare system serves and who it doesn't. Think about how the profit-driven system impacts not just patients and physicians, but businesses and community health. Talk about single payer, and hopefully give you data that resonates with you. So who is not served? As I talked about, 26.5 million uninsured, 37,000 dying every year from the lack of insurance, with medical costs leading to 2/3 of personal bankruptcies, even when people had coverage. And of course, not communities, and we'll talk about the community data. So this is from the Commonwealth Fund, one of my personal favorite places to get data, but looking both at uninsured and underinsured, or people who've been insured but had a coverage gap. And just looking at the definitions of underinsured, out-of-pocket costs excluding premiums equaled 10% or more of household incomes, or 5% or more for low-income families. That's kind of crazy numbers if you think about it. And then I dwell a little bit on this number, mostly because I'm a gynecologic oncologist. You know, every year there's about 44,000 people who die of breast cancer, about 35,000 who die of prostate cancer. And you just could not imagine an oncologist or a physician saying, we're just not going to worry about those deaths. Which in many ways is what we do when, as a system, we simply accept the idea that there's going to be uninsured, and that's reasonable to have in the health system. As we look at the U.S. Markers of health, our life expectancy is substantially lower than those of countries that we would consider equal to us in terms of income and resources. And interestingly, right, Costa Rica in here not thought to be equal in terms of resources, but certainly doing better than we are. Infant mortality substantially higher in the United States compared to Canada, France, etc. Maternal mortality substantially higher, with considerable differences by race, with the most marked highest rates being seen in African American women, but even for highest income white women, rates that are higher than our similar countries. And this is a really interesting, piece of information, right? Looking at our mortality rate, comparing us to these 17 other peer nations at every age range where we are substantially under everybody until we get to, age 65. What happens then? Universal health care in America happens then. We hopefully will have some time to talk about some of the flaws of the Medicare system now that it is becoming privatized, and the flaws of the Medicare Advantage plans. But even that gives us some information. And then it might be that, hey, we have this great healthcare, like we just need to spend money on it. Now we spend plenty of money, right? We spend a lot more than everybody, both total and in public and private spending. I selected out a few slides of my 70 slides I previously mentioned, kind of the ones that I think matter the most, but there's so many ways in which we can look at the problems of our current care, right? So access to care increasing over time. Either there's a problem and you don't see someone, you can't afford to, or don't fill a prescription, you skip a recommended test, etc. Aren't able to get to a specialist either because they're not available. And a lot of times you say, oh, well, healthcare in America is so much more expensive because we just use more of it. This is not true. We do not spend more time in the hospital. We do not get more visits per capita. And the other data that I flipped, but I took out, but I have to speak of is lots of times people will say, well, America's just less healthy than everyone. No, we don't smoke as much as they do in Europe. We are younger as a population compared to Japan and much of Europe. And so that doesn't account for this. Again, this number that I've cited several times already, this 2/3 of bankruptcy related to medical or illness related work loss. And again, the substantial percentage of patients who had insurance at the time they got sick, 77%. So where does our money go? This $4.3 trillion we're spending, 34% roughly, we believe about $1 trillion, over $1 trillion is in administrative spending, where the largest proportion of that is insurance companies and profit. And then there's the billing systems within hospitals and offices, although that's changing as offices and physicians are being swallowed up into these big organizations. Thinking about total healthcare system administrative expense, comparing us to Taiwan, that does have universal coverage of all everyone there. Looking at the difference between traditional, that is not Medicare Advantage, but traditional Medicare overhead of 2.3% versus United Healthcare of 18.5%. This is like one of those slides that always gets my heart rate a little up, right? We're talking about physician shortages, and meanwhile, we continue to have just dramatic increase in administrators in healthcare. Imagine Duke Medical System with about 960 beds, 1,600 billing clerks, spending about $100,000 in billing costs for one primary care physician, compared to Canada, roughly 1,300 beds with like just seven, one-digit billing clerks. Who else is not served by our system? I touched on U.S. businesses and the potential harms done to them as well as physicians. So doctors spend twice as much time in the electronic billing record as they do with patients. Pretty dramatic, pretty depressing. And then Epic Notes. This is one of my favorite little pieces of data. Average number of characters per ambulatory notes in all of these countries that are sort of our equals, so to speak. And then characters in American notes. Now, is this because we are just so verbose and we just, I don't know, took lots of English classes? No, this is because we need to include all those characters so the companies we work for can bill at the highest rates. Is it malpractice insurance that makes healthcare more expensive in America? This is Rhode Island compared to several provinces in Canada. Well, we just, we make more money as physicians. That's what's screwing up the system. Not so much. This is Canada compared to the United States in a wide range of primary care and specialty care, where essentially I would say relatively equivalent salaries. And then again, I think we need to spend much more of our time talking to what a drain on businesses, both large and small, the burden of providing health care is, which, it's clearly been documented in the auto industry when the United States kind of fell dramatically behind internationally. But even if, you look at, again, this is a Commonwealth Fund surveyed small business owners, asked, what's the biggest challenge facing your business? The cost of providing healthcare coverage to employees, not finding new, customers, developing better widgets, whatever it might be. No, cost of providing healthcare. So if it's not doctors, if it's not patients, if it's not businesses, if it's not, our communities, who is served by our current system? Health insurance industry, the pharmaceutical industry, now increasingly private equity, and of course the CEOs and shareholders of those companies. I took out a lot of slides about the pharmaceutical industry, but I had to leave this one in because this is the other conversation I frequently get when I'm talking, is, but we need those insurance companies and drug companies. They're doing all that great research. How much do they spend on research and development? 13%, versus marketing and admin and profits. But we know that admin includes salaries, so that's kind of part of profits. So our money goes to these companies and their profits and to their CEOs in compensation. These are smaller healthcare companies, again, with just these millions and millions in annual compensation. And then the profits of the nonprofit systems, whether they're university systems or systems like Kaiser. All right, this is kind of a weird slide. I give a lot of talks to patients. I give a lot of talks to Integrative Oncology Group. And usually it's like around here when I'm looking at the salaries of CEOs, my blood pressure's up and my heart rate's up. So everyone's going to do a little quick breathing exercise. You're going to breathe in through your mouth for a count of 4. You're going to hold for 7. You're going to breathe out for 8. That's one breath. I want everybody to do 4 breaths. I'm only doing one with you because I'm going to keep talking. But we're going to do it now. We're going to breathe in through our mouths for a count of 2, 3, 4. I can see you guys. You're not breathing. I'm going to start over. We're going to breathe in through our mouths for a count of 2, 3, 4. You're going to hold 2, 3, 4, 5, 6, 7. Then you're going to breathe out 2, 3, 4, 5, 6, 7, 8. You guys are going to keep doing the breathing exercise. But I almost put this in as a joke to myself. You know, those other talks that I'm giving to patients or I'm giving when I'm talking about integrative oncology, where like that sort of parasympathetic tone change that we do for ourselves when we take those breaths, they do decrease our blood pressure, they do decrease our heart rate, and they have the potential to help health, but they do not have the potential to solve the problems either for the United States or for us as individuals, right? So when we think about solutions for the US, we're going to talk about single payer and the different terms we use. And then for us as individuals, right? You know, the majority of the people on this call, you're already here, you're already spending your evening, you're asking questions, you're getting data, you're joining this community. Many of you all already belong to PNHP, but I'd encourage those of you that don't to consider it as a way to use your voice. I'd encourage you to vote, to give talks, to talk in small and large groups, and to meet your legislators. So we previously looked at this slide, thinking about why single payer or improved Medicare for all provides a solution. There's a lot of very experienced single payer advocates on our call on this group tonight, but I'll just remind us all that we've had a real evolution of the language, and we're going to have to continue to evolve our language as Medicare has been chipped away by the Medicare Advantage plans. So again, all medically necessary care, no copays, deductibles, or premiums, no need for supplemental insurance, with nobody left out, including, you know, no restrictions on age, employment, or immigration status. Everyone's covered for your entire life, no pre-existing conditions, and free choice of doctors and hospitals. So thinking differently about healthcare funding, hospital funding, where we use global budgets, a place again to save administrative waste, and thinking about the idea, right, that, you know, mental health, addiction, labor and delivery, not profitable. And so many parts of our country, especially in rural areas, not having access to this care. Predictable, stable funding, even during crises like COVID, where again, we had such gaping holes in our ability to provide care. So again, comparing that commercial insurance with narrow networks, unaffordable premiums, the need for prior authorizations, and then ongoing changes with Medicare for all. Free choice again, all care covered, all medically necessary coverage, no interruptions in care. Can we afford it? From all of the data, we know that 95% of households would pay less than they currently pay in premiums, copays, and prescriptions. Is it feasible? If we think about the savings and where that savings comes from, the administrative cost, you know, drug device negotiations, that savings, what we're planning on spending more money on, the rest of the people who are uncovered, that 9 to 11%, we would still save money. And then I think the other challenge is depending on how we ask this question, right? Most people support the idea of Medicare for all, and then we start couching it in terms that are red and blue and socialism and labels, and we find ourselves in a different place. And again, the idea that over time, even among physicians, we're seeing increases, so that now the most recent data I have, 2017, shows more physicians supporting Medicare for all. So, you know, just a final plea for this concept of it really, really is hard to be a practicing clinician. Um, Many of you guys on the webinar tonight have heard my personal story and challenges of providing specialty oncology care. And ultimately, it's working with PNHP. I was actually at Northwestern, that was a long time ago, really struggling. And somewhere along the way, I got a email about some kind of presentation that was being made down, in Springfield on a possible single payer option, and kind of had some knowledge about it. I, of course, had my PhD in cost analysis and public health at the time, and I was like, I don't know what's going on in Chicago. I'll just go down to Springfield and see what's going on at this hearing. And at the hearing, I can't remember, I kind of made some sort of comment, and I was approached by Nick Scala. And he was like, wait, are you a physician from Chicago? I got a group for you. And, that was the beginning of a beautiful relationship. I was lucky enough to have Claudia sit down with me and go through the first slide deck. And I gave a couple talks, and then I came back and I was like, wait, Claudia, they asked me these questions, help me. And I would encourage those of you, who are considering joining, to use the resources within this organization to do just that. I don't know. I think, oh, look at me. So I didn't leave us a ton of time. I guess we're at the hour. Oh, no, we're not. I left us. I thought we had 30 minutes and we do. Okay, awesome. So I'm going to take a look. This is the QR code if such things appeal to you. And if you'd be interested in joining a PHP, if this is not a comfortable setting for you to ask questions, to have thoughts, and you'd like to chat, you can email me, you can reach out to PNHP. We can find people who are your specialty if you feel like that would serve you more than talking with a gynecologic oncologist, though of course I'm happy to talk with you as well. So I'm going to stop my sharing so I can actually... and maybe one of y'all, Mandy or Lori, will you throw the QR code into the chat if you guys have that capacity? Or the links, that would be great. I'm going to stop the share and then pull up the chat so I can see questions. Wait a minute. It is totally impossible that this group does not have questions. I'm thinking it'd be great if you could put your questions in. Can you get access to the talks? Absolutely. So we will find a way to get my slide deck in, but all members of PNHP have access to a huge range of talks. All the talks from our annual meetings. There's a resource that is on. Okay, now the questions are just rolling in. And I'm losing track of them. So let me go back. The AMA not only does not have a stance on Medicare for all, our student chapters have been working very, very hard to at least remove some of the anti-single payer, anti-Medicare for all languaging in the AMA. We're not quite there yet, but that is ongoing work. Is there a subchapter for... So we do not have subchapters. We are broken up by state and by region. And depending on what your interests are, you can reach out to us and we can find your local chapter, or we can work with you to find you ways to be active through the national organization. Can I expand more on the calculation of the budget? Can you give me more details on what questions you want? Janet, yay, excited you're ready. Reach out to Lori, me, or Mandy. How to get this done politically. So that is a really challenging question. I'm actually going to drop the chat so I feel like I'm talking to you guys as I answer that question. PNHP has been around for 35 years. And for a long time, we really believed that the um, way to do this was to provide data. And, you all are familiar, if not, we can help you be, with Steffi Woolhandler and David Himmelstein's work, Adam Gaffney, so many researchers doing amazing work. And it was a bit of a learning curve to realize that it's not just data, that we need to do more. And the things we need to do more are engage more physicians and grow the membership of PNHP, to build better coalitions, to work with non-physicians, to work with other advocates, to work with unions, to work with other healthcare movements that would benefit from single payer, like the reproductive justice movement, and to strategize better with legislators. We are a 501c. We do not take a side in elections, but we certainly can work with people who are in those positions. And sometimes it can be challenging because they certainly don't do the things we want. But I think all of those things mean that we can do it. What are the standard objections? I'm gonna grab that question because I actually have a slide in my deck that I can pull up on that. It's my opinion on physician unions. I think because we need to organize and because we need more physicians in the movement, unions have a strong role. Traditionally, as professionals, the idea was that our medical societies, such as the AMA, and our individual societies would play that advocacy role for us. And, working with some of the lawyers who are coming at this from a different direction, there's a movement called the corporate practice of medicine movement. There are laws on the books preventing corporate practice of medicine and corporations telling physicians how to practice that have essentially been ignored. And there's a physician group, docs, there's lawyers groups and different advocacy groups who are pushing on this. And their belief is that, that we shouldn't need unions because we shouldn't have employers, right? That that ownership of practices should be in the hands of physicians. That said, I think we're a ways from there. And so I support unions as a way to give people voice. Do I dream of a time that we won't need them? I do. How does private equity affect us? Private equity is sucking medical practices dry. They don't even pretend that they are any way engaged in the business of healthcare or the business of doing anything else other than making money. And I think on a practice to practice basis, it's challenging, depressing, and sad. But from the perspective of how will it help the movement, I think it's going to help us, because I think the abuses are just so crystal clear, and private equity has done damage to, other businesses. Later this month, I'm speaking at a American Economic Liberties Project that's focused on how private equity is damaging many different businesses, but specifically reached out to us to talk about it in healthcare. So I think it's bad for healthcare. I think it's good for the single payer movement. Hey, Michael, I see you have your hand up. If you could pop your question into the chat, just so I'm being equitable, since we sort of requested that everybody not do a handhold. It's a big group tonight. Thank you. How many states have single payer movements that include a bill? I don't know the answer to that question. If there's somebody on our call that knows the answer, please put it into the chat. We have a lot of very experienced single payer people. How do we recruit? We do webinars on Thursday evenings now. We traditionally give grand rounds. That's one setting. And oftentimes it's people, family practice, OBGYN, pediatrics, lots of different practices. And for many of us, that was our introduction into single payer, was that. I do think, though, ultimately the best recruiting we can do is by us as individuals reaching out to our colleagues who are struggling to practice medicine. Um, and Pam, I love this question because it relates to this. Who will define medically necessary? Professionals will, doctors will. The way we've talked about how we structure this system, who makes decisions, that ultimately we make that a combination of professionals who are trained to know the answers to questions, as in, is an ectopic pregnancy, a surgery for an ectopic pregnancy, an abortion? No, it is not. Right? Answer medical questions. And ultimately, that's what we'll need. Does it have the potential to be complicated? It absolutely does. Um, but a combination of, professionals, of patients and patient advocates, ultimately is how we've talked about it. We are blessed in the single payer movement that students are our largest. I'm just addressing one of the comments and questions. Medical students are some of our most active and effective advocates. And I do think we need to reach out to physician assistants and nurse practitioners. I've been disappointed. One of the other movements I found interested is the Take Medicine Back, and they're a group of ER docs who are specifically focused on thinking about this corporate practice of medicine and pursuing legislation and talking more and more about private equity in healthcare. And unfortunately, I think they have some languaging that alienates other healthcare providers, because I think there are challenges when ERs are taken over by groups like Envision and physicians are, slowly moved out, and they instead are put in charge of multiple PAs or NPs. But the idea that those PAs or NPs are the enemy is just inaccurate. Our system needs them. We just have to figure out the right place for everyone, and we need to get them involved in the movement. My PA from my last job is a member of PNHP. Yay for me. I'm looking to lots of great comments, looking for questions, top barriers. I think the barriers are challenging. I think a lot of them are fallacies. The ideas that, we are not going to have autonomy, that our government is going to be telling us what to do. And I find that really challenging, because I feel like, how could I have any less autonomy right now? When United is telling me what test I can get and how long it's going to take. So I think we just have to talk about, what's true and what's not. And I think that, at least within PNHP, we have spent a lot of time and energy looking at this and talking about it from a true, what's best for patients and what's best for community health measures approach. And we haven't always remembered to talk about why this is good for physicians, and I think we need to do more of that. What is the pro-con of states versus national single payer? How about we set up another hour talk and I'll cover that entire topic. I think that there's benefits I think both movements are essential. I think as an organization, PNHP National has been challenged by limited resources, and so we are focusing on national single payer. But absolutely, most, if not many, of our members across states are engaged in state movements, and they play a role at every level, both in the potential to achieve single payer and in the work of educating and recruiting. I see power of stories, absolutely. You know, we just recently applied for a grant. Hopefully, we'll get it. We'll find out this month. But where hopefully we'll have some financial support to elicit the stories of physicians and patients and the challenges of our highly financialized system, and how that impacts rural areas, how that impacts different populations. Um, I'm looking through your guys' questions. Will Medicare for all cover nutritional services? Charles Francis, you speak to my heart. Um, I think there's a lot of, you know what, I had promised that I would look at some slides. It might be hard for me to start sharing my screen again. Um, so one of the ways we got here is a healthcare system, right? There were a lot of political movements that had nothing to do with healthcare. You know, why in Harry Truman's day, when he proposed, a universal healthcare system, did the AMA not support it? And unfortunately, that had to do with racism and the desire not to cover, people. And even now, I will frequently hear, though, why do we need to cover, immigrants? Well, because they're like keeping our economy going. But, and so there were we know that some of the limitations that have been placed on healthcare, things like the Hyde Amendment, have some misogynistic concepts at their base. And certainly, if we go even farther back in American medicine, when we basically decided that Western rational medicine was above women's medicine or above indigenous or herbal medicine, that was kind of the time we sort of basically bailed on all lifestyle medicine, right? We bailed on preventive health, we bailed on nutrition, and then we started diagnosis codes and only paying for, you know, procedures and treatments that were expensive. And that's kind of when we lost this, when we lost nutritional services. And slowly, I think we are gaining them back in. Will they be covered? Absolutely. Um, you guys have a lot of oh, here I have a direct question to me. Some medical specialists and surgeons are opposed because they're concerned the bureaucracy would continue. Um, what I'd say is change is difficult. I think specialists have set up systems around them. They've found a way to, make a system work, and are afraid of change. But, there's a group called Ortho Forum, that's orthopedic surgeons coming together to fight against private equity in medicine. And to me, it means we just need to talk about salary, talk about who's going to be making decisions and help them, talk about eliminating the burdens of documentation and pre-authorization and denials, and restoring autonomy, kind of the same way we talk to everyone. I don't know, Mandy and Lori, I hope you guys are looking at the questions. If there's big questions that you don't think I have touched on that we need to get to, I see lots of answers. Oh, here's another direct question to me. As most people are healthy and have not had to deal with a serious illness, I believe we need to make the personal economic argument about costs of current dysfunction. I I'll be honest, I tend to come at it from a simpler perspective. When I'm giving this exact talk to non-physicians, and I often hear that, like, I don't want to lose mine, don't take my healthcare system away from me. I tell stories of my patients who thought exactly the same thing and didn't expect to get ovarian cancer and not be able to work full time as a nurse or a teacher, um, and kind of the consequences of that. I think the other way I talk about it is if you had a budget, and your budget was whatever amount of dollars, and 30% of that budget or 35% of that budget was getting sucked away, and you could suddenly get it back into your budget. You know, Dream of the things you could do. That's where we are right now with our healthcare budget in America. We are giving away 30 to 35% of every dollar that is not being spent on healthcare. I'm trusting you guys, Lori and Mandy, that if there's some questions that are things that I really need to touch on. Thank you, Bill, for adding that in. One payer states number about 25, so that's about half. That's great. Plunder, Kenneth, that's a great book. I am my second go through on my Audible. Really interesting, talking about private equity beyond healthcare, but even on all these healthcare adjacent, right? ERs, um, uh, ambulance services. Even right now, private equity is taking over fire prevention, which is kind of scary to me since I always use that as, how healthcare is different from other commodities. And I've compared it to fire services. Thank you to everybody who's answering these questions. I'm just looking for other questions. How many specialty medical societies and other presenting this data at their annual meetings? There's not a lot of openness. I have struggled with getting this presented at a Society for Gynecologic Oncology, but one of the strategies that PNHP is taking, it has been presented and agreed upon in pediatric settings, family practice. I think Phil and one of our other members spoke at the National Pediatric meeting, as well as a College of Physicians. I'm going to be wrong about that. I'm sure somebody will help me say the right thing. But it's challenging. So how we are approaching it is by targeting different medical societies to go to their meetings and have a table at their, where the other pharmaceuticals and everybody else gets to have a table. And one of the things we're hoping to be able to present, if we are able to get this grant we applied for, is that, talk about moral injury, get people interested, have them take our surveys, have them do interviews with us and tell their stories, but also have that be a chance for us to introduce these concepts to them. Yep, and I see another direct messages to me. Jessica, thank you for including that. I mean, I was just reading Michael talking about Medicare rejecting claims. Many of those are Medicare Advantage. But what I was going to say, when I was listening today about the data breach of United Healthcare and what's it called, Health Change or whatever it is, and the Senate hearing yesterday, I think there are so many opportunities for us to talk about what is flawed in the current system. Yeah, Mary, I agree. I worked for Kaiser myself. What is UHC? I don't know where that's coming from. Universal Health Care. Oh, thanks, Mandy. Yeah. And thank you, Krita, for including that cost of Medicare for all article in the Lancet, and the links to the CBO data as well. There's a fear with Medicare for All that the system may have to ration care. I don't know what to say other than, aren't we rationing care now? You know, here in the Norfolk Chesapeake area, the average time it takes to see a cardiologist is 7 weeks. The average time to see an endocrinologist is 3 months. The average time to see an orthopedic surgeon, if you don't have a break that needs an operation, is somewhere in that range too. Um, we're 3.5 to 4 hours from, the nation's capital. And so um, it's hard to say we're not currently um, rationing care. The concept that most medical specialists and surgeons receive kickbacks. Um, as both a surgeon and a specialist, I guess I'm going to I'm going to want us to reframe that as we discuss it. So there are a whole bunch of things, for example, that the ACA put in place, right? That if oncology groups could show that they were providing cancer navigators, that they would be reimbursed at a different rate. Now, I'm going to argue that cancer navigators help patients. Unfortunately, what do cancer navigators mostly do? Help people navigate our complicated system. So, is the solution like sort of, I think the solution ultimately is not needing navigators for things like that, having access to care. Um, I just want to be careful about the languages we use when we say kickbacks, right? Um, and then I see this discussion about fraud, but fraud is about setting up systems that ask for gaming, right? That's what upcoding is. But if if we set up systems that were not profit based, we would change this. So at this point, I feel like I've been rambling. Um, and I guess that's the challenge of having a large group where we don't have enough time to talk as individuals. And so, what I would encourage you all to do is to connect with your state group, to email me directly, to reach out to PNHP members, to continue these conversations where it's not one of us talking at you and trying to answer your questions through a chat. I see there's 57 messages that I haven't had a chance to look at, and I apologize for that. Um, but I'd look forward to us to continue to have conversations. One of the things we talk about when we have groups that ultimately end up with this kind of input is that we set up longer times, we set up 90-minute times, and then we set up breakup rooms so that people who are new to the organization have a chance to talk to people who've been with it longer, or we could set up conversations in different ways where everybody gets a chance to be in a group of people who live close to them regionally or practice the same kind of medicine, whether it's OBGYN. But I look forward to all of your requests of how you think we could serve you best in helping you to advocate for universal health care free of profit-driven motives. Um, and again, now there's 62 new messages that I haven't gotten to. I'm going to leave that last minute. Mandy or Lori, do you have other thoughts you want to add to our wonderful group in the last couple of minutes we have?
I'll just say thank you so much, Jill, for engaging us in this really incredibly interactive and exciting and interesting conversation about Single Payer 101. And thanks to the audience for really engaging in the chat. We just want to do one last reminder that on June 3rd is a Medicare Advantage webinar. We'll put maybe Mandy can put the registration. You can register tonight and you will get reminders. And if you're not a member, join, because the way we're going to win is with people power, physician power, medical student power, healthcare advocate power, family power, children power, grandparent power. So let's all get together and fight this fight because that is the way we're going to win. Thank you all. Have a nice evening. Thank you so much, Diljit.
Thank you, everybody. Really appreciate your giving us this time. Look forward to engaging you in smaller group venues or one-on-one. Thanks again.